And how to interpret any profile? There's 1 plus and 1 is to 100.
Yes.
Which letter is significant?
So the inclusion criteria only will say it should be more than 1 in 80. So 1 is to 80 is the titer which is cut off, and then 1 plus is again not so much significant. It should be more than 2 plus to take it as significant.
Okay, this is very important. And third thing is usually as a general practitioners and physicians, so we'll start some temporary painkillers and then small dose steroids, which is the safest painkiller to start with for the joint pains, and which is the safest steroid or the dose to start with. Still further referral is made.
To start with, again, depends on the severity of the patient's complaints. If the patient has got severe arthritis, like you will be thinking 5 mg of Vizolone would not be sufficient, you can start with 10 mg. So that's
Vizolone is better.
Vizolone or Omnacontin.
Okay.
And if you want a short-acting drug, Hydrocort would be better. Hydrocort is a choice. And painkillers, NSAIDs, usually I would start with Coxib, Etoricoxib, and with muscle relaxant like Etoricoxib with thiocolchicoside combination should be better. But if you have a suspicion that patient has got any kidney issues or liver issues, you always go with paracetamol, Dodo, or the safer medication, other alternatives.
Okay. And what is your take on that? Now there is so many new drugs around, especially monoclonal antibodies, and they're quite expensive but has a good results. So which are the commonly using monoclonal antibodies now, and any other emerging therapies now?
There are so many things which are coming up in rheumatology. Rheumatology is an ever-growing branch. So the biologicals, we call it in a simple term as biologicals, is a targeted therapies. Targeted therapies are, it will target only a particular cytokine or a particular pathway. Like there are TNF inhibitors, TNF alpha inhibitors are there, interleukin 6 inhibitors. So these drugs will target only interleukin 6. So it will go and stop that interleukin 6. So there are JAK-STAT pathway inhibitors, there are interleukin 17 inhibitors. All this will come under biologics. These are all targeted therapies.
So which are the commonly used now? What is the cost approximately? Anything used for the RE?
Yes, rheumatoid arthritis, we have got this TNF inhibitors like infliximab, adalimumab, cetolizumab, golimumab. So cost varies again. Cost will differ. Approximate will be around 20,000 per injection, 20 to 25,000.
Because most of this monoclonal antibodies expensive.
Yes, and nowadays we are having these biosimilars, which are coming at affordable rates.
This is usually monthly or.
So the dose schedule will vary according to the drug used. So infliximab is it is given every 2 monthly. Adalimumab again we give injection. It's a subcutaneous form which is given every 15 days.
How long?
So we give it for 6 months and see the response, and then we can taper it down.
Okay.
And then maintain with the oral medications.
Okay. So what is the role of telemedicine? Because for example, people are not accessible. So rheumatology doesn't need any interventions and other things. So telemedicine has the potential to. Yes. They can even at the distances, they can have schedule a video consultation and consult. So how
digital health and telemedicine, we have got so many apps now. So they are just one click away. So if you want to see a patient, categorize a patient, you want to diagnose a patient, you can just click on the criteria and then apply the criteria. If you want to know the severity of the disease, particular disease or the patient, we have the apps which will tell about the disease scoring apps like DAS score, which just needs tender joints and solar joints, which when you enter, it will show the score, which will tell about the severity. So based on severity, again, we can decide on the medication options and treatment options. Following up also is easy when using these apps, like WhatsApp app or other digital apps, video calling, Zoom calling. All these are really helpful for people who are really staying far away and the follow-up is difficult in person. So all these people can have a follow-up on these digital apps. And also it is all helpful for the referral, cross-reference between GPs and rheumatologists or other specialities in rheumatologists. When they have a doubt, we are just one click away. So all doubts can be clarified using these apps.
So there are common 3 to 4 red flag signs which practitioners should not neglect and refer to the rheumatologist. And commonly you have seen people who have missed this red flag sign and you have noticed that they should not have missed it. Any such things?
So as I told you, all back pains are not sciaticas or disc bulges. All knee pains are not OAs. Like if you are seeing a young patient with joint pains, you can't label the patient as osteoarthritis straight away. And all back pain should need an inflammatory workup. And if you have a recurrent red eye, it can't be taken as conjunctivitis only. So there is some autoimmune thing which is going on. And if the patient is having fever which is not subsiding with the routine medications, and the patient has got this rash on the face, ulcers which are not healing, so all those things will not be just normal diagnosis like a routine diagnosis. All these non-healing things, non-explainable things will need an autoimmune workup and rheumatological workup needed.
Okay. So we discussed most of the essential things about only first video about the common public, second video what GPs should have, some basic information, when to refer to rheumatologist and when to take it. So thanks for the video, Dr. Anusha. Thank you.
Thank you so much.